Okay, no.
Okay, let me pull it up. Thanks, Jackie. All right, so we can get started. So first, approval of the minutes from January 13th.
So I move approval of the minutes from our last meeting, January 13th. And so I guess you have to second since there's only two of us.
Well, Kristen is here.
I'm an alternate.
Oh,
she's our alternate too, so yeah.
Oh, great.
Oh, great. All in favor?
Aye.
Any opposed? Okay, great. Our meetings from January 13th are approved. So today we have Paul. Paul, I'm going to mess up your last name, which I think is Alderetti, from the Denver Department of Public Health and Environment to talk about health equity, which is a topic that our city council has been talking about fairly frequently, and more so with COVID-19. So Paul, I'm very glad you're here, and this is a great time, and city council will be discussing our equity efforts around COVID-19 tomorrow. So we really welcome this conversation, and I'm sure that Jackie can give you a much better introduction.
No, thank you for that, Councilmember Gorgel, and thank you. You were, I think, heard Paul speak and came back, and when we were having our brainstorming session with the Council Futures Committee about future topics, this topic came up and you suggested Paul as a speaker and connected us. So thank you so much for that. And Paul and I connected pre-COVID to plan this session. And I just really want to thank Paul for being such an amazing regional thought partner, because as the date was nearing, we thought how much had changed and yet how much health equity seemed like such a more than ever relevant topic for this committee. For those of you, we have over 30 folks joining us virtually, which we know that Futures Committee, Council Futures Committee is often an intimate gathering in our, we usually have it in our CIC room and in City Hall. So we're really grateful to have this opportunity to all gather together virtually. But for those of you who are joining the first time, because I know we welcomed some of our partners through the Home to Health, which is a lot of great work happening in the housing, health, and equity space, and others in our city organization and community. This is open to the public. The Futures Committee is one of Council's official committees, and it's a pretty unique committee that we actually get asked about quite a bit from other cities, and it intentionally is meant to give Council and city leadership and the community an opportunity to have a dialogue with thought leaders on various topics and really kind of pop our heads up when we are every week so busy with our Council agenda items to really think about the long-term health of our community and the long-term outcomes in our community, and what trends should we be paying attention to now and responding to now to kind of work towards that preferred future and vision. So we have lots of different topics. Our mayor always refers to it as a think and do tank, that we think together and have dialogue, but that lots of things have been sparked through this committee over the years. And so we're really grateful as we think about being in the middle of a global pandemic to be thinking about the future of health equity. And again, huge thanks to Paul for evolving his presentation to be really responsive to what we're seeing now about the future of health equity. So I just want to give him a bit of an intro, because I think it's really helpful to know the context of your speaker. And so again, so grateful that we have this partner in Denver, but I'll share a little bit about Paul's background. So Paul currently serves as the health equity advocate at the Denver Department of Public Health and Environment. And for over 30 years, Paul's professional endeavors and personal commitment have focused on creating a more just, equitable, and sustainable society. Since 2013, this work has concentrated on equity, public health, and the built environment. And prior to this, Paul helped design and implement programs and public policy related to energy, climate change, social responsibility, and sustainability. So our triple bottom line approach in Fort Collins is, speaking Paul's love language. So we've had some great conversations. Paul has worked with government agencies, corporations, trade associations, nonprofit organizations, utilities, and other groups throughout the United States and internationally. He's a graduate of CSU, so it's got some ties to Fort Collins, and his greatest learning opportunities came as a Fulbright Fellow in India, as an adjunct professor of sustainability at Naropa University in Boulder, and in his work with diverse communities. Paul is a native of Colorado and a long-term resident of North Denver, and his most important job is being husband to a remarkable woman, father of 2 amazing men, and father-in-law to another wonderful woman. So with that, I'm going to pass it over to Paul, who will be sharing his screen to kind of take us through some thought-provoking trends around health equity and what COVID has been teaching us during this time. Paul, I'll pass it to you.
Great. Let's see. Great. Can everybody see this?
Yep.
Looks good.
Good.
Okay, great. Let's rock and roll. I'll take no time in pleasantries. I do want to thank Jackie and Councilwoman Gogal for inviting me. This is a great opportunity. And as Jackie said, this is really important that we have this conversation right now. Although COVID has been an absolutely horrible thing for so many people, whether it be through the disease itself or through the economic and other consequences of this, this is a time, I believe, to really take stock in what kind of future we want to have. You know, the whole COVID experience has shined a light on what health equity and what equity in general is really lacking in our society, whether we see it from the experience of people who are most vulnerable, and whether that, again, that be from health or economics. We often have these equity conversations in kind of an echo chamber, and we talk about it. And although we work with these communities in essence, it can be really remote and even sometimes theoretical. That's ended as far as I'm concerned. I believe a lot of other people feel that way, because now all of us are having a different experience. And in some way, we are all having the experience that many communities who are most vulnerable have had for many years. And I think it's kind of given us a whole different perspective. So one of the things that I'm doing this year that I've actually built into my work plan is to go back and really take a look at the COVID experience and think about what we have learned and where this takes us into the future. And I've created a framework to have that analysis. And there's 3 points to this framework that I think are really critical. The first point is, how do health equity and health disparities show up in public health events like COVID-19? You know, what is the experience? What have we learned by being in this place? The second is, how can an understanding of public health events like COVID-19 help us make the changes necessary to reduce inequities and disparities that increase vulnerability? And as I started out by saying, this can be a real changing point for us as a society, to say, what have we learned? And let's not go back. You know, there's a lot of this talk about let's go back to normal. I think if we go back to pre-COVID-19 normal, we have lost a tremendous opportunity. We have to start thinking about how this becomes a pivotal time in history for us to create the kind of society that we want. And then the third point is, how can we improve our responses to public health events to reduce the negative impacts to vulnerable communities? So the first point, and people confuse the first point and the third point. The third point is really, how do we build emergency plans based upon what we know, so that if we ever have to go through this again, this basic shutdown in society, those communities that always get hurt don't get hurt as badly. You know, I give the example of a community I do a lot of work with here in Denver called Globeville, Elyria, Swansea, that's just north of I-70. And just a couple of weeks ago, I was on a call with members of that community. And I said, how many of you have actually know someone who has gotten COVID? And there wasn't one person from the community on that call who had had that personal experience. Then I said, how many of you have suffered from the economic consequences of our response to COVID? And everybody on that call had that experience. So we have to have a plan so that the next time this happens, we don't want it to happen, but we can't keep our eyes closed to that we are ready, and that the plan that we implement is not going to victimize those communities that are already victimized for so many reasons. So the first piece of this that's really critical is understanding what we're talking about when we talk about health equity. This is actually, the presentation I'm giving you today is a presentation I'm going to be giving to everyone in DDPHE, because we realize that we have to have a common language around health equity, especially in our agency, so that when we are talking about it, everybody is coming from the same place. And when we do talk about it, this is really critical that we recognize these persistent institutional biases and barriers that create obstacles from health. And that's really where we come from. I'm going to go through some of these slides. I'm not going to read all of this, but almost everything that you see here is on our health equity website at DDPHE, and hopefully I'll have time at the end of this to show you how to get to that. So the definition for health equity that we use really comes from the definition created by the Metro Denver Partnership for Health, which is a collaborative among the 6 health agencies in the 7-county Denver metro area. And that is that health equity means that everyone has a fair and just opportunity to be as healthy as possible. Now, there's 2 key words in here that are really critical, and that is fair and just opportunity. Because often when we talk about opportunity, we open the door for people saying, oh, well, there's a community that had the opportunity and they just didn't take it. And we all know that that's simply not the case. I use the analogy that we sometimes say people need to pull themselves up by their bootstraps. But if people don't have any boots, it's kind of hard to do that. So that fair and just is really critical whenever you tie opportunity to equity. I love this definition of health by the World Health Organization because it talks about a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I think that gets really critical as we start digging into this. We really focus on health outcomes when it comes to health equity. And there's this social ecological model of health outcomes that we use as the basis of these conversations, because it shows that health outcomes are the result of a whole series of layers of things that lead to whatever health a person is experiencing. And in each of these, there's a whole complex web of things that interrelate to each other. So at the bottom of this are the individual attributes of race, age, ability, sexual preference, gender or gender identity, and the genetic health characteristics. And these are the things that are hardest to change, over which we have not a lot of control, if any. And then you get into some of the social factors that deal with culture and social relationships, discrimination and bias, culture. And then you start getting into those things that are more institutional and systemic, whether those are personal choices, environmental factors, socioeconomic factors, or these institutional and systemic factors. So when we at DDPHE talk about where we do our health equity work, it really comes in everything from personal choices to the institutional and systemic factors. This is where we do our interventions, whether those be policies, regulations, programs, projects, investments, or even individual assistance and support. This is all built upon the idea of health disparities, and the Kaiser Family Foundation defines a health disparity as a higher burden of illness, injury, disability, or mortality experienced by one group rather than another. And again, this looks at disparities across many dimensions, and this becomes the basis of our conversation around health outcomes. This is just an example of how you do that and of how that shows up. There, when you get into this graphic and realize that there are adjoining neighborhoods in the city and county of Denver that have as much as a 10-year difference in life expectancy. That is disturbing, but it's not sufficiently disturbing as when you look at how it translates in potential years of life lost. So what that's saying is if you have 10,000 people in the community and everybody has a 10-year disparity over someone in the next time zone, you multiply that 10 years by 10,000, and that is the potential years of life lost for the members in that community. And when you think about this in terms of, I mean, you can think about it in economic terms. What is the economic loss of all of that to us as a full community, not just those people, but to everyone in the community? And then you think about it on the human scale, and it just starts boggling the mind. So the other thing that we do, a lot of our work is based on data. Well, I would say all of our work is based on data. We're a very data-driven effort when you look at health outcomes and health disparities. But I want to come back for that data element in just a moment, because it's not about getting lost in the numbers. We recognize that these conversations are no clean slate. And this is a map we actually have on our health equity website. This shows the overlap between our equity index and systemic barriers that have been going on for years. So this map actually takes our equity index scores, and you can see the scores there in the key in the lower right, and it overlays those on a map of communities that experienced redlining, which are all those communities in with the hash marks. And what you see is that there's an exact or almost exact correspondence, so that you can really see how inequity is not just where we are now, but has been going on for decades to lead to where we are now. And in fact, it's a multi-generational issue. So all of this is great, and it's great to have these conversations, but what we really want to do is build a health equity practice. And our health equity practice, and we believe this is true of anyone who practices health equity, intentionally supports policies, delivers public services, and allocates resources to advance health equity and eliminate institutional biases and barriers. Key word in here is intentionally. This is not something you do as a side project. This has got to be built into the DNA of your services, and not just your services in the health department. This cuts across everything a city does, because all of those things contribute to health disparities and health inequities. When we take this approach, there are really three key questions. Where do those health disparities exist? What geographies? What populations? This is where data really comes into play in understanding what's going on. The second question is, why do these health disparities exist? And that's where you start going into that model that I showed earlier and start digging down and start asking difficult questions about every one of those levels and how those advance or impact health disparities. And then our third question is, how can DDPHE improve its programs and services to remedy these health disparities? And actually the second part of that question is, how do we work with our partners in city government to bring this information to them and together to do that? Because we just don't do it on our own. You know, when you talk about economic disparities and how that advances and how that leads to health disparities, we don't do economic work, but our Economic Opportunity Office certainly does. And then we take a three-part approach. We align this work across not only all of our work in DDPHE, but across the work of the entire city, so that we're doing this in an intentional and strategic way. We advise, we act as a resource to others, both within our department and across the city, to think about this. And finally, we advocate for this. You know, it is no accident that my title is Health Equity Advocate. And it's something that we've really pushed. And I have to give commendation to our leadership at DDPHE for actually asking that's, you know, giving us that title. Sorry, Jackie, was that, I heard a sound. Was that my cue that I'm running out of time?
No, you're doing great, Paul.
Okay, great. So we see a four-part process in doing this work. First, identifying the health outcomes, and then analyzing the contributing factors to those outcomes. Then we plan and identifying strategies to address contributing factors, and then we implement them. These policies, programs, regulations, projects, investments. And then we go back and say, how are we doing? So that's why this is a circle. There are four distinct steps, but it comes back, and it's a continuing process. This recognizes that as frustrating as this can be, it's a job that's never done. We, in looking at health equity at DDPHE, look across four key aspects. The first is learning. It's really understanding, and that's not just about us learning and about us teaching. It's that interactive conversation with other people about health equity so that we all understand it and can develop that common knowledge, that common language. The second is collaboration. It's about working together. It's about, none of us can do this on our own. This is not a silo. As a matter of fact, one of the things that I love about this work, I love bridging things. It's something I've always loved, to put things together in a way, you know, it's the Lego approach to life. Health equity can help us do that. It presents something that connects all of us. The third is community. If you are not working with community, you're never going to get there, because their voices have to be at the table in a meaningful way. You know, it's one of the reasons I don't even like to use the term community engagement anymore, because it sounds like one of those boxes we check. We only talk about community involvement. And the fourth is data. And what I was going to say, what I referred to earlier in saying that I wanted to come back to data, is this really is not just about numbers, because numbers often do not reflect the experience on the ground in communities. So when we talk about data, we're talking about numbers and information, because we always take that data and then say, is this really reflecting reality? And if not, why? What is the disconnect? Is there something wrong with the data? Are we asking the wrong questions? Are we asking about the wrong data? Is there something that the community is experiencing that isn't reflected by the data? How do we put those two pieces together? So when we talk about data and information, it's about the numbers and how they come together with the lived experience. It's what we call ground truthing. For those of you, I don't know how many of you are familiar with that term. I love that term, and it's really critical. So when you overlay that approach with those key aspects, all four of those things show up in each of the four parts of the process. And this becomes your blueprint for having an internal conversation by overlaying those key aspects into the four parts of the process. I alluded to this earlier. To me, the wonderful reason that we have this conversation in the context of health is that it's an experience that everyone shares. So I've been doing racial equity work with the Government Alliance on Race and Equity. I know you all are members of GARE. I've met some of your staff at the GARE National Convening. There are other ways of approaching equity, but some of those are very difficult. And the conversation around race is a very difficult conversation. That is not to say we should not have that conversation. We absolutely must have that conversation. but health is something that every one of us experiences. So if you're a mother of a child in North Cherry Creek who suffers from asthma, you can understand the experience of a mother of a child in Globeville, Elyria, Swansea. It may be an entirely different experience, but there's that common point of understanding that becomes really critical, that brings people together. This is just a statement on our website by our executive director about how health equity is really the foundation upon which we build who we are as a department. And that's it. Here's my contact info. I'm going to try to escape out of here and get back to the screen. Actually, what I'm going to do I have a second, Jackie?
Yes.
Okay, I'm going to try to pull up our website so that I can show that to you, because our website is not meant to be just kind of our propaganda, if you will, but to actually be a resource for others to use. So when you Google Denver Department of Public Health and Environment, it's probably going to, this is what you get. This is our home page. And just so you know that when I talk to you about the importance of health equity to us, health equity is the first thing on our navigation bar. And when you click on that, that brings you to our health equity website. Almost everything that I showed you is in here. You can pull it down, see definitions, look at our mission and roles, look at the key aspects that I talked with you about. We have health equity data in here, and then we have a whole bunch of tools and resources. So if you want to look at community involvement, what we've done here is there's all kinds of ways of things that you can go to that provide guidance on that. In the assessment and planning tools piece, there's this Ontario Equity Impact Assessment from the Ontario Ministry of Health. Actually, I'm building ours off of this. This was created in 2012. It's the best I've ever found, and it's been road tested for 8 years. So I really love this piece. I urge you to take a look at it. And I'm going to stop.
Well, thank you so much, Paul, and also thank you for showing us the resource that all of us can access that has additional resources. And again, just so amazing to have you right here in our region, because I know we're going to continue to partner and learn together. So Councilmember Gorgel, do you want to facilitate kind of the question and answer period with the committee and others?
Yeah, I can do that. Thank you, Jackie. Thank you, Paul, for that presentation. And as a public health practitioner and someone who works in health equity, this was great. And I really look forward to the conversation with my other council members and the community members that are here. Data is something that we are just starting to look at and collecting more of that data. So I think that's an excellent conversation for us to have. But I think first I'll turn it over to Julie and then Kristen to see if they have any questions. And then Jackie, would it work for community members present to put questions in the chat? Is that the easiest way to facilitate that?
That's what I think that's a great idea. So if people want to chat, to write it in the chat, or if they're able to even just note that they have a question with their name, we can call upon them that way too.
Oh, perfect. Okay, great. So let's start with Julie and then Kristen, and then we'll move to the larger audience.
Thank you. Hi, Paul. Thanks for coming, and thank you so much for the work you're doing. So I have 2 questions I wrote down. I may have more later, but I think we got a lot of people here, so I'll let them. I don't want to take all your time. So my first is when you were talking about the circle and the different pieces that fit in, you were talking about the policies. Can you go a little more into depth about how you interact with your local government? If it's similar to the way, since you are a Department of Health in the government, like how do you work with your elected officials, I guess is the question I'm trying to ask.
Sure. So Denver's a strong mayor system. We're very different in terms of the structure of our government than like Fort Collins with a city manager. We are part of the mayor's office. So we have, needless to say, a rather strong relationship with the mayor's office. We are there as a resource for city council people who want to learn more. We provide data ecumenically to anyone who wants to use it. We put it up on our website. I think the real key is how we work with staff in other agencies. And I think that the most exciting part of that is that it's been very organic. And I won't waste a lot of time in talking about that. But for instance, when I was part of a group that was involved in building our new Blueprint Denver city planning document and our new comprehensive plan. And when you go into those documents, equity is foundational in those documents. And just that experience kicked off this really exciting amalgam among staff and all those departments to come together, to talk with each other, to question this. So I'm hoping this answers your question, that it's partly making a decision that this is going to be a part of it. So that's kind of the top-down version of this, but it's also a bottom-up one where staff are working together and bringing this. And again, you know, that's great on the policy side. And I would say it works something like this. When we're working on the program level or the project level, then staff has a lot more freedom in doing this kind of without, I don't want to say without the blessing of senior management and elected officials, but it's what we do on a day-to-day basis. And it's about how we integrate that into what we do. But then you have to have the other piece, because if you're trying to work within a inadequate framework, then you have to change those policies to provide guidance and freedom for the staff to do what they're going to do. Did that answer your question?
Yeah, it did. Yes, it did. Okay, my next one is completely different, but so in the last 2 years or so, I've gotten kind of involved with the Colorado Foundation for Universal Healthcare. And so I am curious of where you fall on the universal healthcare, universal Medicare type debate, if it even is a debate, or if you do any research on that those sorts of, oh, what's the word I'm looking for? It's late, sorry.
No, that's all right.
It's been a long day. But, you know, those sorts of initiatives where the groups that are trying to get a universal healthcare type system going in the United States.
Well, we don't specifically advocate for that as the solution. Part of it is just political reality that, you know, if in fact the mayor was to say, we as a city are going to get behind this, then we would get behind that and would support that. But that's really not, that level of detail for a specific policy is not something that we do within DDPHE and within the health equity practice. I would say the more important part of that is identifying what the goal is, less than what the specific tool may be. And when you look at health disparities, a large part of that is inadequate access to healthcare. And there are many reasons for that. There are economic reasons for that. There are geographic reasons for that. There are even cultural reasons for that. And so what we want to do is identify all of those and present that information so that policymakers can say, this is what we need to do to ensure that, whether it's a universal healthcare law or, you know, whatever that looks like. And I would also go so far to say is there is probably no single way to break that ice barrier. What you have to do is look at the entire range of issues. That's why when you look at that diagram, the social ecological diagram for health outcomes, you have to understand the whole picture and say, what do I have to do in all of these places to get to where we want to go?
Great, thank you. And sorry for the politically charged question there. All right, I will go on to Kristen then.
Great, thank you. Thank you, Paul. So as policymakers, we're dealing with a lot of different topics and stuff like that. So can you kind of give an example of some kind of policy that was created because of the data that you were able to show to policymakers, and it was something that's been effective that you feel like has really changed some outcomes in your community?
Boy, it's difficult to do that because one, our effort's like a year old, and so I feel that I, as the health equity advocate, and my colleagues doing this work around health equity, have largely still been in the phase of us building the foundation. And what I go back to what I just said about this being at the top down and the bottom up approach. There's a lot of work being done across agencies with us, like working with our public works department, on looking at when you looking at something as we talk about data and somebody's asked a question about data, where are the places where people are being killed or seriously injured due to traffic fatalities? That's obviously a health issue, but it's also a public works infrastructure issue. And those are the kind of approaches that we take, is to say, when you come at this from a health perspective, it just lends a different part of the conversation and a different emphasis. So a lot of that grassroots stuff, it's kind of an interesting thing, because I think our health equity practice, even before I was brought on, and I was brought on a year, it'll be 2 years in August. I mean, that's how my tenure has been. We were still approaching health in something called health in all policies, which is a term you may all be familiar with. We've kind of feel like we've outgrown that. But I like the term. I feel it's health in all policies is very limiting, but I like the description of how it serves as the basis for everything that you do. And I would also, this is going to sound like a cop-out, but I often say that we all are immediately start looking for solutions without asking if we're asking the right questions. And I would say we're being much more, we are trying to be much more methodical in asking the questions before we come to the outcome, so that we can ensure that the outcome actually addresses the questions. Again, I hope that didn't sound like a cop-out.
No, not at all. I hear what you're saying, and I think that that's really important. And as a policymaker, I feel like, people want action, right? And so when you see those disparities in, life expectancy or whatever, and they're very troublesome, and you want to stop that, I think that we as policymakers are like, oh my gosh, what can we do? And I think you're right. It's probably important for us to take a step back and understand that, and then have a, holistic approach to solving those type of problems. I just, there again, so maybe that shows my anxiousness of trying to fix a problem before I know what the problem is. So I guess just one more question. So with the COVID, we're seeing a lot of things in our community, disparities that, we're always there, and that are just, really coming to the forefront because of COVID. What are you seeing? And, I agree. I think that this virus and this pandemic provides us an opportunity to really address those problems going forward. But what are you seeing in Denver, and what, what do you think we can do there again? I'm sorry. I try to be a problem solver. So, but just a little bit about what you're seeing with COVID, I guess.
And first of all, it's fine to be a problem solver. It's good to solve problems instead of sitting here and having these discussions about how many angels can dance on the head of a pin. Before I get back to the COVID thing, I think the other thing that you raised that I think is really critical, and I try to capture it in that second to last slide, is when you have conversations with your constituents about issues that those constituents may not feel attached to personally, I think that if you have those conversations around health, they can then understand in a very personal way why they should be concerned about it. That thing about health being the common experience in all of our lives as human beings, I think is really powerful, and I don't think we use it enough. So I'll tell you that. Going back to the COVID thing, I mean, we could have a 2-hour conversation about this, but
I'm not going anywhere.
Well, let me just tell you this. I think that, let me give you one example of the conversations that we're having. We can have conversations about people who are experiencing the health issues associated with COVID. The deeper conversation is this conversation about the social and economic impacts of people, not only of the disease itself, but about the steps we have taken to address the disease. And I don't want to get into the cure is worse than the disease. Believe me, I do not want to go down that road. But having said that, when you, and I'm going to tell you this because I've just been a part of a conversation today about this, about the frontline workers and about people who have no choice but to go to work no matter how much it endangers their lives. We're doing a lot of work. I'm involved right now. I'm on our department operations team for COVID. I'm specifically working with the data team to analyze data within the context of health equity. One of the things that we're taking a big look at is the situation in long-term care facilities. And we can have conversations till the cows come home about the patient's experience and the nurse's experience in that. But what about the people who clean the bathrooms in those facilities? And why are they there? And the fact that they don't have sick time. One of the things that I was talking about today is we need to tell them, you need to have a plan for those people. You need to have a plan to get them tested to ensure that they're healthy. And not only that, but you have to have a plan to test their households, because frequently, because these are lower wage, lower income folks, they live in large households with lots of people, intergenerational households. So have you thought about what requiring them to come to work, either economically or however, and then they're going to go home, and what is their experience going to be because of this? So, that's the level of detail. Those are the kind of questions you have to start asking yourself about what the experience of this is. And I go back to what I said at the very part of the discussion, that working in a very low income community like GES, that none of those people have experienced the health outcomes, but every one of them have experienced the economic outcomes. And we know that economics has a direct line to health.
Thank you. Thank you very much. I'll let somebody else have a turn.
Thank you, Paul. And the mayor just joined us, so welcome.
Hey, Paul, how you doing?
Good. Wayne, how have you been?
Good. It's been a long time, and thanks for doing this. And I apologize for being late to you and my colleagues here for parachuting in late. But I've always looked forward to whatever you're involved. You bring great value, so I appreciate you being here. So I'll be here and I'll look for the wrap up. But thanks for the conversation. I've been on for about 10 minutes.
Well, one of these days I'll come up and when we can get together again, not have to social distance, we'll grab coffee or some other beverage in Fort Collins and catch up.
Love it. Thanks,
Great.
Paul.
We have some questions from the community members, if you wouldn't mind, Paul, taking some more time to answer questions.
Sure.
Great. I can read the first one. What are some key types of data that you recommend collecting, and how has that changed over the years?
Well, I can't talk about years because I'm a novice in this. Boy, I don't even know where to start unraveling that. Again, what I think is really critical is if you start with the outcome or the disparity that you're trying to address, and then you go through that model I shared and ask the questions about for instance, what are the environmental issues associated? If you know that you have a geography that has a high, or a community, maybe it's more than a geography, and you say, what are the health outcomes? And you go through that model and you ask in each of those areas, that's when you then ask what data you need to help you support that. Data is easy. We can get all the data we ever want, but making meaning of the data gets really critical. And I think that if you go through this process of asking those questions, then you can say, where do we get the information that we need to answer that question? And then data becomes, data has meaning. It becomes a tool. And I'm really copying on this one for the person, Caroline, who asked this question. And part of it is, if you want more information about this, you might go onto our data page, or if you really want to dig into this, contact me. I'll put you in touch with Maggie Kaufman, who's our health equity data person, because she can really tell you more. And I'm sitting here rattling off, and she could tell you exactly probably what you need to know. Sorry, I don't want to act like a data expert because I'm not.
So, Paul, I have a question for that. When you were collecting data about the health outcomes to direct your practice, is that something DPHE collected, or is that something you worked with community partners or hospitals on? And so how did you find those health outcome data?
Well, I would say a lot of the data that created the health equity index that's on our website that we use as kind of a basis. We have, a lot of it is census data. It's, I don't know if you've ever played, there's a tool, I used to be with the Denver Regional Council of Governments, and we had a HUD grant. We created this tool called the Health Equity, or the Denver Regional Equity Atlas, or I'm sorry, I just zeroed out on it. And you can open maps and you can lay all these data layers, so you can see what is the overlap between race and income. You can do all this mapping on it, and that was a really powerful tool. And now actually, I think it's Colorado Trust that's funding a statewide version of that. And it's because it's data points get really interesting when you start overlapping them and saying, not only how does this piece of data itself work, but how do those two come together? So I just went down a rabbit hole. Can you ask me your question again?
I was just talking about where the data for the health outcomes came from and who you worked with. Yeah,
that initially, but there's tons of data and data resources. I mean, the CSU down here has, oh gosh, and I'm going to zero out the name of it. I can get back to you. It has a group that's working with Colorado Trust actually on their equity atlas that has some of the most amazing data people that I know involved, and they're doing fantastic work. And I was going to look and see if I know the person who's there, but I just can't. Is it Colorado Futures? I can't remember. I'll get back to you on that.
Is that Jocelyn Hiddle?
Yeah. Well, no, it's actually Jennifer.
Okay.
I'm sorry, folks.
That's right.
It is late in the day, believe me. And Jennifer Newcomer who used to work at Garrett Community Development just went over there. And I haven't gotten her new address down there, so I apologize, but it's CSU down here. Of course, yeah. It's CSU. Go Rams.
Great. No, I think this is a helpful conversation for our conversation tomorrow at council when we're talking about our equity work and data. So I know that Jackie's probably taking lots of notes, and we'll talk about this again tomorrow. We have two questions I'm going to combine about what your work looks like around addressing health disparities for undocumented immigrants during COVID, as well as historically underserved and frontline communities.
You know, this is so critical. This is one of those points where policy becomes really critical, because you can have all the good intentions of the world, and I'm going to say some stuff here that I don't mean politically, so I'm going to frame it that way. But the fact is the biggest issue about that we have run into is having conversations with the people in the community and assuring them that because of our conversation, ICE will not be knocking on their door. People don't even come to meetings anymore, community meetings, because of their fear. And some of it is entirely justified and some of it isn't. And, you know, it's perceived, but it's no less real because they perceive it than if somebody was actually at their door. And I would say that the biggest experience, the most important experience that I have with this is that we're not going to the community as the government and trying to work directly with the community because of all of the issues related to that. We work with community champions and we partner with them, because even if we had the resources to do this on our own, the perception of it coming from a trusted source gets really critical. So I'm a big believer in working with people in the community. And actually, that's really part of the essence of our approach to working with community, is that government, tend to go to community when we want something. And, you know, even if something beneficial, like we want to help you. But when do we bring community to the table to design those mechanisms for having that conversation interactively and having it driven by the community? You know, when we got involved, we've been heavily involved in GES because that's where the I-70 reconstruction is. And, but we have framed the conversation with that community as, you tell us what your issues are. This gets that piece I was saying about what is the data versus what is the lived experience, so that we can start putting those. We can tell you what the asthma rates in those communities are. We know that. They're terrible. We know that. What is their lived experience to check that and to bring some kind of understanding about it and figure out together what we need to do so that they're at the table. And that community involvement piece is a really critical piece. And I think all of us in government have to get better at how we approach community and involve community from the very beginning.
Thank you, Paul.
That was
no.
You know,
it was great.
We met at the meeting. We're having this exact discussion.
Yes, this is a discussion that we could have all day, I think. And I think the importance of, having community-led processes, especially with the government, and turning that table is an important part of health equity work. And so I appreciate you talking about that. And, we recently at council were talking about community engagement fatigue and, not just checking off that box and having the numbers, but not fatiguing people and having that feedback loop and really bringing people to the table in a meaningful way.
And by so the way, paying them to be at the table.
And paying them to be there. And so I think it is a area of growth that we can look at the city. So I appreciate you bringing that up. I think we talked a little bit about data and those indicators of success, which was one of another questions. And you pointed towards that website. And it looks like the last question we have is about identifying existing policies that may be barriers. And if you have like an analysis for different new versus existing policies.
Actually, we do. And I would guide folks to that Ontario Ministry of Health tool that I showed you off of our website. That's where I'm building ours. It's really important. I mean, the existing policies, in a sense, are become rather obvious when you start digging into it, and especially because, and you know, I refer you back to that the map that I showed you that shows you the overlap between health disparity, health equity, and redlining. The first step in recognizing these kinds of things when you're looking at policy is this isn't something that just happens yesterday. You're never starting at ground zero with this thing. There are decades that lead to this. So, you know, we as public people, as public officials, as staff or whomever, come into this with the highest ideals, saying we would never do this. We don't support it. And oftentimes what we forget is just by doing the same thing, we are perpetuating something that has existed for decades and not even realizing that we're doing that. So really digging down into understanding where our policies came from is a really critical piece of this. And, you know, I think one of the things is that we come into this, as I said, with the highest level of ideals. And I think that there's something very human about saying, oh, I would never support redlining. But how are you supporting the effects of redlining, even if you don't realize that? And that's a much harder conversation. You know, I always say that whether it's working with community or whether it's working on policies, there is a really critical piece of this work, and that is to come at it with humility. And it's hard. It's hard for people who have master's degrees in public health to not say, I know what's going on. I know what's good for you. It's hard for you as elected officials, and I don't mean this in a bad way, but it's hard for people to say, I need to humble myself and really understand what's going on here and admit to what I don't know and learn from you and learn from other people so that I can understand this more. And that's just a really hard thing for us to do. And part of it is, it's not just ego. I don't want to make it sound like it's ego. Part of it is I want to get to the solution. And the other part of it is just, it takes time. And we want to get to the solution. Not only do we want to get to the solution, but we want to get to the solution quickly. And there are things that we're going to have to triage that have to be done now. But to ultimately solve these issues, it is going to take some time because we're undoing things at the same time we're trying to do things.
Great. And I love that health equity map and the overlay of the systemic and historical barriers. And the county health department here just came out with a health equity map for Fort Collins, and we have been using that. But I like that overlay of those and something we can look at doing it here. I think that, you know, Fort Collins may have not had redlining, but we do have policies and historic and systemic barriers that are causing some of the same adverse health outcomes, just as redlining would have. And so really looking at how those have impacted and gone throughout the decade. So I appreciate those comments.
I'll almost guarantee you that you had redlining.
Oh, great. I think that's been a debate, and I think Wade and I have talked about if we have had that. And so I think, looking back through those historic documents. So I don't see any other questions from the community members. And if any of the other council doesn't have questions, I'll have Jackie wrap it up for us.
Well, I hope this was useful for all of you. Before Jackie wraps it up, I will tell you what I've told her, that, to say what has been said before by people in better places than I am, this really is about community. And it's about how we all work together on it and learn from each other, and how we are thought partners. Because no matter how different Fort Collins are and Denver are in terms of the structure of its government, the fact is there are a lot of good people working in both places who learn better from talking to each other than they do trying to do this on their own.
Okay.
And I can say that without saying that you should hire me as a consultant, because I'm just trying to figure out how to retire.
All right,
Great.
thank you. Yeah, go for it, Jackie.
Ready to summary? All right. Well, I will say I was texting with some of my colleagues that we couldn't have asked for a better tee up for our work session tomorrow night, where, as Councilmember Gorgel mentioned, we will be coming forward to talk about one of Council's adopted priorities, equity and inclusion, and specifically some of the work that's been accelerated because of COVID. And so just thank you so much, Paul, for your partnership in Denver, because I know I'm taking tons of notes as we think about framing and the conversation tomorrow. So a couple, just summary points, and Mayor, to bring you in, I'm going to help try to make it feel like you were here for the whole part, was that, Paul's beginning, I think, is such a powerful statement as we think about having a futures committee, which, as we think about health equity and COVID, that it's important that we don't go back. And I think, that's what the futures committee is all about. And in terms of that, as I thought, the point of it's not just about doing things in new ways, but also undoing some things. And when we think about that through the equity lens, I think, a lot of ties to the work session we just had with council as well around social and economic recovery, and how we're centering that in equity here, and that how we respond and recover and regenerate, which is a past futures topic here too, post-COVID, is really thinking about how we make sure that in future shocks, that communities that have been disproportionately impacted will do better because of what we're learning during this time, doing in new ways. So a lot about kind of the not going back and what does next time look like. Yes, of course, all the talk about data was very timely, because we will be, as part of your adopted priority, that was one of the key items that you wanted us to work on, was establishing those equity indicators in our community so that we can be data informed about really having that comprehensive understanding about disparities in our community, knowing that during COVID, those are being revealed and deepened in new ways. And so being data informed with that, but then kind of the conversations about wanting to be problem solvers and what are the exact policies and programs that we need to put in place, that yes, having that data will help to inform that, but that it's about building that holistic understanding, and then kind of the approach to community. How are we co-creating with those most impacted, what the response is, and making meaning of that data together, especially with those with lived experience in those data points. Definitely some talks too about the importance, when we talk about that, yes, it's a different governance structure in Denver, but still applicable as kind of the grassroots and grass tops approach coming together. Something, that Paul mentioned was our membership in the Government Alliance for Race and Equity, and that annual meeting was canceled due to COVID. But one of the sessions that we were invited to for council members to know was talking about how staff and council members, our electeds, have aligned so well around this topic in terms of the work that we've been bringing forward, and the work that you're guiding us is just in this really amazing alignment point. And so we're so grateful for that. Thinking about health as a common experience, how how important of a point that is for all of us right now during this global pandemic being experienced locally. And then, the importance of learning together, which is what this Futures Committee is all about, bringing in external thought partners. And so it's great to have those here in the region, just a drive away. And, a lot of what was kind of discussed too reminded me of a session that I heard of the equity vice president of eBay, that he said in this work, it's all about overtime, not overnight. And that's really challenging when there's so many urgent issues. But that was kind of a helpful reminder from the talk today. And as I mentioned, we have the work session tomorrow. So that's a pretty clear next step of this work, that we'll be having that dialogue with all of council tomorrow to check in on this priority with you, give you some updates, get your guidance, especially that we are just starting to launch the equity indicators work. So this is such a great time for us to get your guidance on that and have this conversation today. So that's the summary. And if I don't know if I missed anything, but those were some of the key takeaways, plus lots of notes of resources I'm going to look at.
Very good. Well, thanks.
That was a great summary, Jackie.
It was. Thanks. And thanks, Paul. And thanks, Emily, for sharing. And thanks all.
Yeah, great. And thank you, Paul, so much for joining us and answering questions. It was really helpful for our talk tomorrow. All right, so our next item on the agenda is upcoming future topics. And Jackie, is that something you are covering? She may be frozen.
Yeah. Yeah.
Can you hear me okay now?
Yeah.
Yep.
I know that it's late, but I know we brainstormed topics for this year, and we have a great list. And I also know
So I also know that, everything's changed with COVID, and so wanted to do a check-in about your interest of any new topics that you want to make sure that we get on the agenda as we think about, the future of Fort Collins kind of post-COVID. So I wanted to just take a moment to pause as we think about strategy and utilizing this monthly committee, and if there was anything different that you wanted us to bring into the agendas.
This is Julie. I have kind of a suggestion just based on what's been happening here for the last 5-6 weeks, and maybe like the future of work and what work looks like might be something interesting if we could fit that in. I know I had a conversation with the upper management at my company this morning, and where they are in DC, things are starting to lift, and they were like, yeah, we don't really feel like we need to go back to the office, even if they want us to. So I don't know what that would look like, but maybe just throw that there in the list. Yeah, that's just the one that came off that I thought of right away.
Great, thank you, Councilmember Pinatero. Exactly, like those sorts of things that we think might be changed forever from this process. What is kind of some of the futures we want to be thinking about?
It's hard to be clairvoyant, but right in the midst of it. But I think there are certain things that, no contact deliveries and things like, there's certain things that, so just what are those things that might persist and, value free, but just think about those things, and then how that framing might influence a lot of conversations that we have.
This is Darren. One of the things that comes to my mind is a more pragmatic perspective we have on the digital divide, and really how debilitating it really is in an environment like right now. And it's a real issue for us because we're working directly with PSD as of this morning on that, but it's it just is very clear to me how some given the past model, could have real advantages and others not so much at all. In fact, a serious limiter as we look to move forward. So that's one thought that I have, Julie, in response to your question.
Well, I would say Darren stole my thunder. But I would say that, and then also, as Paul was talking about, people who are doing those real community-led processes and examples of what that would look like would be great.
And then maybe another one. This is Darren again. Maybe another one, and I don't think now is the time. But at some point we probably ought to do thinking around the way in which not health policy has been made, but it's sort of the who's co-creating in the midst of COVID, and co-creating, I mean messaging and decision making and some of those sorts of things. So I don't think now is the time, but I do think as we're looking out to the future beyond the next 6 months, I think that's something that we ought to put on the parking lot for now, but come back to, because I think there's been a lot of lessons. As I've said before, we've got a lot of great experience in floods and fires and tornadoes and things like that, but this pandemic, I think there's been a lot of learning, and so I think it'd be smart to have the Futures Committee talking about that.
Great. Did we give you enough of a list, Jackie?
Yes, I was just going to say that is awesome. Thank you so much. And we'll work on that. The final question for you all is the other one that we did have scheduled during this time. So we had postponed, I believe, our April one. And Paul, thank you so much for being here for the May. The other one we had scheduled, but we wanted to confirm with you all, was that one around kind of the voice of the future with some local youth that are part of our youth advisory board, as well as some of their colleagues. And I have been in contact with some of my colleagues at PSD identifying some youth for that. So we could still schedule that for June. And we know that what they might share probably has changed a lot too, because their young adulthood, their youth has been significantly impacted during this time. But it was to really hear from them what they're thinking about in terms of their future. So I'm seeing nodding heads. So it sounds like is there support to move that forward as our June futures, and then we'll start working on populating these other great ideas post-June?
I'm fine with that.
Yeah, I'm fine too. I guess, are we just sort of going to play it by ear if it's in person or another digital meeting?
I think that is the case right now. It looks like Darren might answer, and kind of from an organizational perspective in terms of how we're handling meetings post-May. But I will tell you that our tech-savvy youth are more than prepared to join us digitally if that's where we're at.
Well,
that's a really good point.
Yeah, I think, Julie, it relates to your first question too, and and it's maybe as you and your team at work talked about how you do things differently, and how for some people telecommuting has been a fabulous experience, and productivity shot up, and in others it's not worked so well. I will tell you, I think. I know that some of our remote meetings have been more convenient for city council members and more convenient for some of our residents. We hear from some that it's been less, but I also know it allows people to participate without making huge changes or taking an hour of travel time or whatever. And so I know that in talking, for example, Kristen's on the line. I hope this is okay, Kristen, but even as a leadership planning team, the meetings we have on Monday mornings, Kristen posed the question last week, boy, my life is easier when we do this remotely because of the complexity of our day job and other things. So I actually, Julie, I think the bigger Futures Committee conversation is how we don't go backwards, that from a alternative transportation mode, from an air quality standpoint, from a total health wellness, all kinds of reasons why we ought to be having those conversations. I would love to have council giving thoughts about that, and I think our workforce practices will be altered as well as a result. I hope we don't go back to the way we used to do it, but I'll just sum it up by saying, you know, I've heard from council members saying how remote participation can really help them do their jobs better, and emphasis on jobs, multiple jobs. So I don't know if there's any response to that, but Jackie, that might be a way to take Julie's first question and turn it into a future topic.
Yeah, well, I would just say here. I mean, it has made things easier for at least my situation. I think everyone's situation is going to be different, but
right.
But there are certain topics, well, and I don't know, maybe if we do that, we should be aware in futures of certain topics that would be better done in person. And we could even look at different venues instead of that room, right? So whatever that room's called, I already forgot.
The CIP? Been too long.
Don't forget, that's an important room still. Oh.
That's right.
Okay.
All right, great. Well, I think that is everything for today. Just checking the comments. All right, Paul has to go. So thank you again, Paul, for joining us and all the information. It is truly appreciated. All right, so if there's nothing else, I think we're done tonight. Thank you, Jackie. Yeah, thanks for the summary, Jackie, and bringing Paul in. It was really appreciated.
Thank you for the connection, and it was awesome to see how many people joined us today inside and outside the city organization. So thank you, everyone.
Definitely, thank you. All right, good night, everyone.
Bye.
Good night.
Okay,
Take
bye.
care.
Oh.